Hello again. Let's say we have a patient with cellulitis, so your garden variety skin infection. Before we just switch to autopilot and prescribe our usual antibiotics, first we need to make sure that we are not dealing with a condition that will require a completely different treatment plan, meaning either a prolonged course of antibiotics, different kind of antibiotics, or maybe even a surgical procedure. So what kind of conditions am I talking about here? Well, this localized skin infection can become systemic. It can spread and cause sepsis. The bacteria can penetrate into the bloodstream, and from there they can spread all over the body to cause metastatic infections. But also this local skin infection can spread locally to involve the deeper layers of the skin, but perhaps even the tissues like the fascia, muscle, or bone. And finally, this cellulitis could be caused by some unusual bacteria, something that will not be covered by our usual antibiotics. Because the antibiotics that we usually use to treat cellulitis are intended to cover Streptococcus species and Staphylococcus aureus, the most common causes of cellulitis, but there are plenty of other potential causes, and then we need to be able to suspect them in time so that we can prescribe a broader spectrum antibiotic. Okay, so now that we know what we are looking for, let's turn our attention to the red flags. And just like always, we first observe our patient's overall appearance and we measure their vital signs. I always say that, but why do we do that? Well, we are looking for signs of systemic illness. In other words, sepsis. If you want a more detailed explanation on how to suspect and diagnose sepsis and serious infectious diseases in general, I suggest you take a look at my free online course. You will find the link in the description of this video. You won't find anything like it on the internet, especially not for free. And if you work with acutely ill patients, this will help you a great deal in practice. But okay, back to our vital signs. In these discussions on infectious diseases, there is always one vital sign that stands out, and that is body temperature. In other words, the presence of fever. And for what I'm about to tell you, it's very important to know whether fever started before or after the local symptoms of cellulitis first appeared. Because if you are dealing with erysipelas, this is a very common type of skin infection. It involves only the most superficial, the outer layer of the skin, right? If you are dealing with erysipelas, it will usually start with very impressive, abrupt, general symptoms like high fever, rigors, chills, maybe vomiting, and only after a couple of hours will the local signs of infection like redness, edema, and pain first appear, right? Many of your patients will already know that they're about to get erysipelas because they will be already very experienced with it, unfortunately, because it tends to recur. So, general symptoms first, local symptoms later. This is typical for erysipelas, and erysipelas is usually very easy, very straightforward to treat, and serious complications like bacteremia, sepsis, metastatic infections are very uncommon. That being said, many of these patients will be hospitalized for a short while because they will have these impressive symptoms. The affected area of the skin can be quite large, so they might need intravenous antibiotics for a couple of days, but then they will typically get a lot better, so you will be able to switch to an oral regimen. But again, serious complications will be very uncommon. So this is erysipelas. General symptoms first, local symptoms later within a couple of hours. But when the opposite happens, when your patient with seemingly localized cellulitis suddenly becomes febrile after a couple of days, this is almost always a huge red flag. And if you see this, you have to suspect significant complications, namely sepsis. Of course, you will hospitalize these patients, and please don't forget to take at least 2 sets of blood cultures. Why am I emphasizing this? Well, remember I told you how Staphylococcus aureus is one of the most common causes of cellulitis, and staphylococcal bacteremia, staphylococcal sepsis is no laughing matter. It's notoriously difficult to treat. Metastatic infections like endocarditis are very common. So again, at least 2 sets of blood cultures so that we make sure that we detect bacteremia if it is present. So this course of the disease, cellulitis first, fever later, this is a huge red flag. Okay, so much about systemic complications. What about local complications? Well, whenever you have a patient with cellulitis, make sure that you examine the affected skin very carefully because you are looking for signs of a skin abscess. An abscess is a collection of pus, and typically it will need to be evacuated. So a surgical procedure will be required. This will not go away with antibiotics alone. So how do you suspect an abscess? Cellulitis is painful by definition, right? But if you find a spot that is particularly painful, so way more painful than the rest of the affected area, you should suspect an abscess, and many times you will even feel it fluctuate. It's kind of like you are touching a water balloon, a very painful water balloon, but you simply have to do it. If you suspect an abscess, you will consult a surgeon right away. If you need to confirm it, you can use ultrasound or a CT scan, whatever is available. Just remember that an abscess needs to be evacuated. And in the United States, the presence of an abscess is even more significant because it will alter your choice of antibiotics. If you find a skin abscess in the United States, in North America, you have to cover community-acquired MRSA. In Europe, this is not the case. In Europe, thankfully, community-acquired MRSA is still very uncommon, but in the United States, it's absolutely rampant. So please remember, you need to detect the skin abscess for two reasons. One, you will need to consult a surgeon, and two, you will need to use antibiotics that cover community-acquired MRSA. Now, in your textbooks, you will find that necrotizing infections like necrotizing fasciitis or myositis get mentioned a lot. And yes, if you find excruciating pain that is out of proportion with other physical findings, in a patient who looks septic, you will suspect a necrotizing infection right away. These patients will usually have many other red flags, very serious findings like areas of mottled skin, of skin necrosis, maybe even the presence of gas in the affected area. So you won't be able to miss the fact that this person is very, very sick, right? But what I need you to remember is that you have to consult a surgeon right away, because surgery is both the most effective treatment, the only effective treatment, and the best diagnostic tool available, because surgical exploration is the best way to determine the extent of tissue involvement. So if you suspect a necrotizing infection, please call a surgeon right away. But necrotizing infections, fortunately, are something that you won't see very often. But what you will see all the time are infections, skin infections, soft tissue infections involving a chronic wound. And that is what we are going to talk about next. You will see a lot of elderly immobile patients with pressure ulcers, patients with advanced atherosclerosis or advanced diabetes. So they might have chronic wounds, chronic ulcers, and if the area around these ulcers gets inflamed, gets infected, there are a couple of things you need to do. First, you will need to use broader spectrum antibiotics, because these chronic wounds serve as reservoirs for all sorts of bacteria. Yes, Streptococcus species and Staphylococcus aureus are usual suspects, but also gram-negative rods and even anaerobes. In moist wounds like the ones you find in chronic venous stasis, many times there will be Pseudomonas as well. So yes, you will need to use broader spectrum antibiotics. And many times you will need to consult a surgeon, because in these chronic ulcers, you will find devitalized dead tissue that serves as a reservoir for all the aforementioned bacteria, and if you don't remove it, the infection will not go away with antibiotics alone. Not to mention that if you are dealing with a diabetic foot infection, you have to suspect that there might be osteomyelitis in there somewhere. Many times you will be able to touch the bone or even see the affected bone. So a diabetic foot infection is osteomyelitis until proven otherwise. Please remember that. And since we are talking about surgical procedures, there is another point I would like to make. If the redness in cellulitis, if the redness affects a joint, any joint, this is a red flag. You should examine this joint very carefully, looking for signs of septic arthritis. So you should be looking for signs of joint swelling, pain, and reduced mobility. If you find any of that, you will need to take a sample of the synovial fluid. You will need to use imaging, because septic arthritis is much more difficult to treat than your uncomplicated cellulitis. Your patient will require a prolonged course of antibiotics, and the surgical procedure will mostly be necessary because, again, Septic arthritis is essentially an abscess. It's a collection of pus within an enclosed space, right? So once again, you will need to consult a surgeon. And what I just told you is especially important if you're dealing with a prosthetic joint, if any kind of foreign material, of prosthetic material is present, because if foreign material gets infected, the bacteria create a biofilm, which renders them almost completely resistant to antibiotics. So if an artificial joint is infected, most of the time this will not go away with antibiotics. Almost always a surgical procedure will be necessary. This material will need to be removed or replaced, otherwise this infection will not be resolved. Many patients have total hip replacement, knee replacement surgeries. I don't care if it was done 20 years ago, this can still get infected. So please remember, if the redness of the skin affects a joint, this is a red flag and you should suspect septic arthritis. And finally, I would like to discuss a couple more scenarios where you will use broader spectrum antibiotics and perhaps call a surgeon. I already mentioned chronic wounds, but bite wounds as well. If your patient got bitten by a human, a cat, a dog, a raccoon, or whatever, you will need to cover Streptococcus species and Staphylococcus aureus, of course, just like always, but you will also have to cover gram-negative rods and anaerobes that reside in the biter's mouth, right? So you will need to use broader spectrum antibiotics. Of course, many times there will be also devitalized tissue, areas of necrosis, maybe the bite affected a bone or a joint. So naturally, you will consult a surgeon, and please don't forget about tetanus and possibly even rabies shots if your patient got bitten by an animal. And as I always say at the end of these lectures, ask yourself, who is my patient? Are they at any increased risk of having a complicated infection? For example, are they immunocompromised? If they are, don't be afraid to consult a specialist, an infectious diseases specialist maybe. If you like this video, if you find it useful, you will absolutely love my free online course. Again, you will find the link in the description of this video. Thank you for watching. Good luck out there and take care.